Okay, so I'm Sharon Cohen. I'm a behavioral neurologist. I'm an Alzheimer's specialist, and I'm the medical director of Toronto Memory Program. We are Canada's largest memory clinic and also a research site for new treatments in Alzheimer's disease. Thank you so much for inviting me to come speak with you. And as some of you may recall, I was a guest speaker with you in 2024. And you would think in 2 years, not too much could have changed. Well, there's a lot. So I'm very happy to be able to give you an update on what's changed since I last spoke with you. So I also have with me my colleague Justine, who will be very helpful in assisting me with the chat, with any of your questions in the chat. But also after today, anyone who wants to reach out to Justine for any of the services that we offer or any questions you have, please feel free to do so. We welcome that. And finally, just a disclaimer that today's talk is for educational purposes. And it's not meant to be medical advice for any specific person or problem. Of course, we do give lots of medical advice when we see patients, but this session is an educational session. Okay.
Sorry to interrupt. Sharon, can you speak a bit louder, please?
Sure, I will try. Is that better?
Yes, that's better. Thank you.
Okay, thank you. Okay, so my objectives for today, I want to provide you with updates since 2024 about recently approved new treatments. Hooray, finally, some new treatments. And also, what has that done to the system, the healthcare system, with new treatments available? Thirdly, what does the future hold? What will the next crop of treatments look like? And fourthly, I want to provide this call to action for people who want to be more involved with what's going on. So as we think about what's changed, I want to just pause and say some things haven't changed. The fact that Alzheimer's disease continues to be a serious, progressive disease that causes progressive impairment in memory and thinking. It causes a loss of independence over time, and it causes a change in mood and behavior. And this is a highly feared disease that still has no cure, although we're inching towards much better treatments and eventually a cure. Right now, we don't have a cure. And it's an expensive disease, particularly when people get to the moderate stage of disease. In early stages, it is not so disabling, it's not so expensive, but when people get to moderate or severe stages of dementia, that's when families have to come out of the workforce to care for a loved one. That's when you have nursing home placements and all kinds of other services, so it becomes very expensive. Alzheimer's disease remains the commonest cause of dementia. It accounts for about 80% of all cases of dementia. And despite being so common, it is frequently underdiagnosed and misdiagnosed. So that's a challenge. The World Health Organization in 2012, more than a decade ago, stated that Alzheimer's disease is an urgent healthcare priority, and that is still true. The numbers are staggering, more and more people affected. As I mentioned, underdiagnosis, late diagnosis, only 50% of people will ever be diagnosed, even though the other 50% have Alzheimer's disease. And those who do get diagnosed, it's only after several years of symptoms and progressing in terms of their disease. The previously approved medicines address symptoms, that's important, but they are insufficient by themselves because they target stages of disease that are relatively late with lots of brain cells lost, even at mild dementia stages. There are lots of brain cells that are lost and are not coming back. And none of these medicines are approved for the mild cognitive impairment stage of Alzheimer's, where people are still independent. You actually have to wait until you get worse to be eligible for the approved symptom treatment. So there's got to be a better way to treat symptoms, and that will come. What we've learned over time is that Alzheimer's disease is a very long disease, about 30 years or so, with the first 10 to 15 years being silent, meaning no symptoms, changes going on in the brain cells being injured by amyloid, a toxic protein that's accumulating, and tau and inflammation, multiple complex processes injuring the brain until enough brain cells are injured that you tip into this stage called mild cognitive impairment, where you are noticing some change in cognition. A clinician who assesses you can see on a memory test or cognitive test that you're not performing normally, and yet you are still banking, shopping, driving, working, traveling, whatever it is you would normally do, not without some frustration or perhaps some inefficiency, but you are still independent. Seamlessly over the years, as more brain is injured, we get into the dementia stage of Alzheimer's, mild, moderate, and severe dementia stages, where independence is progressively lost. Initially, one may not be able to drive or do one's own finances, but at a moderate stage, one needs help with personal self-maintenance, toileting, grooming, showering, dressing. And at severe dementia stages, people are completely dependent on others for survival. So this is the complex clinical trajectory of the disease. When I was in medical school, I was taught Alzheimer's disease is a dementia. It's a 10-year disease. We didn't even recognize the earlier pre-dementia stages. Now we have a much better window of opportunity to catch people early and change the trajectory. When we used to diagnose Alzheimer's disease at autopsy, we saw amyloid plaque and tau. These were the two bad actors. But now we can see these proteins in life, even at very early stages of disease or at stages where there are no symptoms. So this is a huge advance that we don't need to wait to autopsy to be certain about a diagnosis. That doesn't help the patient, obviously. We know that treating early with the new medicines I'm going to talk about gives an optimal response, but there are challenges to getting people to come early, and there are many reasons for these challenges. A patient, him or herself, may not recognize there's a problem. This is not denial in the psychiatric sense. This is the part of the brain that reflects on how you're doing may not be working well. So a patient may say, I'm fine, my family are complaining about me, but I think I'm fine. So if you feel you're fine, you're not that likely to seek medical help. Other patients are very aware something's changing and they're very concerned, but they're fearful of coming forward and seeing a physician because they're fearful of stigma, maybe losing their driver's license, whatever it is, being told they have a serious disease and there's nothing we can do for you. That is starting to change. More and more people are approaching us early because they've heard of new treatments and they want to know if they have an opportunity. Historically, physicians lacked skill and interest in Alzheimer's disease, and they thought this is much too difficult, much too complicated, nothing to offer people. That is also changing with new treatments. We have physicians now wanting to learn and take part in early evaluations. Another problem that's a challenge in diagnosing early is that early symptoms are often conflated with normal aging, and it can be very difficult to know how much forgetfulness is just part of being, 50, 60, 70, and how much is the beginning of a more serious brain condition. So we all forget things, we all misplace things now and then, we all have a tip of the tongue phenomenon, can't think of a word when we want it. What matters is how much of a change this is from one's own baseline. So if you're somebody with an excellent memory and you never forget things and now you're forgetting things frequently, that's a significant change. If you're someone who's very fluent and never searches for words and now you're searching for words, that's a significant change. But not each individual event is, you're allowed to forget things. You're allowed to forget a word for something, or to enter a room and wonder why you came into the room in the first place. This is normal as long as it's not exceeding the frequency that is your baseline. Finally, the last bullet here, if we make a clinical diagnosis, if I say somebody has mild Alzheimer's disease dementia, but I haven't done biomarker testing, I will be wrong a substantial number of times, and even in experts' hands. Without biomarkers to confirm the disease, we are going to be wrong. And you think about it like a lump, like, is the lump on my arm cancer or not? I need tissue diagnosis. I need, sampling and looking under the microscope by the pathologist to tell me it's a cancer, it's malignant, it's not malignant, or it's a cyst, or it's an inflammatory nodule. So the same with Alzheimer's, we can be wrong if we just go by the fact that somebody's progressively forgetful. Unless we have a biomarker, we're not going to be accurate enough. So what's new in treatment? And a lot has changed since we last spoke in 2024. So in 2023, we actually had the dawn of a new era globally with 2 drugs approved to slow disease, not to treat symptoms, but to catch the disease early when people are still living at home and functioning well, and to keep them stable longer. So 2023, the FDA approved Lecanumab, the brand name is Leqembi, and in 2024, the FDA gave full approval to Denanumab, Kisunla. And each of these medicines are antibodies that target amyloid and clear it from the brain very robustly. They're given by intravenous infusion, and they're indicated for the early stages of Alzheimer's. And what I mean by that is the mild cognitive impairment stage, where we've had nothing before, and the mild dementia stage. And the goal, as I said, is to slow down the disease, keep mild people mild longer. And these drugs are currently approved in more than 53 countries. And here is a very striking image of, on your left, amyloid is red. That's seen on the PET scan. This person has a brain full of amyloid, and after treatment on the right, amyloid plaque is gone. We celebrate that kind of thing when we see a chest x-ray, we see a lung cancer that is present and then has disappeared on a post-treatment x-ray. I mean, it's the same kind of dramatic, wow, where did the plaque go? And both of these antibodies can do that. So what's changed in the last 2 years? Well, as of October 2025, Health Canada, after 2.5 years of review, finally approved Lecanumab, marking the first disease-slowing treatment in Canada for Alzheimer's disease. And the drug arrived in Canada in late January, and now over 200 patients are on treatment since the drug arrived, and many more are lined up to start. In April, just this April, 2026, Health Canada approved the second drug, Denanumab, and the first patients will start to be treated in late July. The drug has just last week arrived in the country. So finally, we've caught up to the rest of the world since 2023, and we didn't have these drugs available and approved when we last spoke. So what about the Health Canada eligibility? Who does Health Canada say these drugs are for? Well, people with mild cognitive impairment or mild dementia who have a biomarker confirmation of amyloid brain change, meaning we know the mild cognitive impairment or mild dementia is due to Alzheimer's disease, not due to Parkinson's or some other condition. And Health Canada says individuals who take Lecanumab or Denanumab cannot have 2 copies of the ApoE4 gene. And ApoE4 is a normal gene that codes for cholesterol transport, but the ApoE4 type, as opposed to ApoE3 or ApoE2, puts people not just at higher risk of Alzheimer's, but also higher risk of side effects from these drugs. In the pivotal trials that led to the approval of Lecanumab and Denanumab, people with 2 copies of ApoE4 were included, and they did well. But Health Canada is risk averse and says, no, if you have 2 copies of ApoE4, the drug's not for you. Health Canada also says that people can't be on anticoagulants. And again, in pivotal trials, anticoagulants were allowed. And if you are in the US, you can be an ApoE4 carrier and be on anticoagulants and still access these drugs. So we have a restricted population that are eligible in Canada, but still it's an important starting point. Patients must be able to undergo MRI scans. So if you have a pacemaker that's not compatible with MRI or other metal in your body or severe claustrophobia, then these drugs won't be for you, because the MRI scans are needed to determine that there are no specific bleeding risk factors before you start treatment, and then with MRI monitoring during treatment to make sure you're staying safe from side effects. So even though lecanemab and donanemab are considered part of the same class, drugs that target and clear amyloid, they are different treatments. They have lots of differences. I've listed a few on these slides, but if one was to have a conversation with one's healthcare provider, you would want to make a decision. Should I go on lecanemab? Should I go on donanemab? And some of the things that would be discussed are the fact that although both drugs clear plaque, amyloid plaque, very successfully, lecanemab also targets other species of amyloid that are even more toxic. And we don't see those on PET scans. So something called soluble oligomers or protofibrils. Don't worry about the terminology, but in order to form amyloid plaque, you have these precursor amyloid species that build up in the brain, and some of them are even more toxic than plaque. Lecanemab is given as a continuous treatment. So when people say, well, how long will I be on this? I'll say, well, as long as you're doing well, we just keep going. Donanemab has a hard stop at 18 months. And some might think this is a good selling point because I only need treatment for 18 months and then I can stop. But it's really based on the mechanism of action of these drugs. Most people have plaque cleared at 18 months on donanemab. So they stop because the target's gone. They're only getting clearance of plaque. Whereas with lecanemab, you're targeting not just plaque, but these soluble species. So you keep going. With lecanemab, we also have longer term data out to 4 years, whereas with donanemab, there's only 3 years data for benefit. And then because patients stop the drug early, we don't have more. Very interestingly, those who start lecanemab and have very low pathology, so everybody's amyloid positive, but there can be different levels of amyloid positivity. So they have low amyloid or they have low tau. Out to 4 years, we've seen some people improve and many stay stable. And even though we're giving lecanemab to slow disease, we don't believe it can arrest disease. Some people with low pathology, so treating early, they are improved or at least stable out to 4 years. So that's really remarkable. And there's quality of life data that is informed by patients themselves saying, being on treatment has positively impacted my quality of life. I'm happy with my relationships, with my living arrangements, with my friends, what I can do, and quality of life for care partners. I'm not overly burdened and stressed. I have enough time for myself, enough privacy, those kinds of questions answered by family members or care partners. So those are some of the differences, not an exhaustive list. So is our healthcare system ready? One of the arguments made by payers is, well, we're not ready for these new treatments. They're not the usual Alzheimer's pills that don't require monitoring. This is complicated. They're given by intravenous infusions. We need infusion centers. We need MRI monitoring. So what is happening? Well, first of all, sometimes it takes a new treatment to really trigger change in the healthcare system. That is the catalyst. And we see a huge number of medical education initiatives across the country geared to different groups, but many geared towards primary care practitioners, family doctors, to help them understand how to detect the disease early so that patients don't miss a treatment opportunity, and what constitutes a good referral so that the specialist receiving a referral can fast track somebody who may be interested in lecanemab or donanemab and not have them sit on a wait list for a year and progress and potentially lose a treatment opportunity. We also are finding with our healthcare system across the country increasing access to the biomarkers we need to diagnose the disease, because Health Canada said these individuals who are eligible must be amyloid positive on a biomarker. And now in some provinces, we have cost coverage for PET scans. That's amazing. We also have more local lab access for the blood biomarkers and also for ApoE testing. Furthermore, the network of infusion centers established across the country has really mushroomed. So we have Bayshore, we have Centrex, we have other major companies involved in establishing networks of infusion centers. I am so lucky I have an infusion center right in my building, so my patients who I diagnose and prescribe can go right downstairs and get their infusions. But the idea is we want people to have local infusion centers so they can walk across the street from where they live and not have to travel distances. MRI training has been really extensive, and there are an increasing number of MRI radiologists and facilities trained to provide the baseline MRI scans we need and the serial post-initiation scans, and to provide this type of reports we need so we can make a decision as to how the person's doing. And I put this in bold here because it's so exciting, this news. July 16, just a few days ago, Canada Drug Agency announced a positive recommendation for cost coverage for lecanemab, and they overturned their previous negative recommendation. They listened, they understand the value of lecanemab in particular. That's the one that they're recommending cost coverage for. And so we will see over the next months, and hopefully by the end of the year, that we have OHIP coverage for this drug, and more to come. And it also gives private insurance companies no excuses not to cover the drug. Okay, so in terms of the original gold standard biomarker test to look for amyloid, we could do amyloid PET scans, but the tracer is in short supply, and most PET scanners are overloaded with oncology or cancer patients, and the scan is expensive. A spinal tap, we do these all the time to sample spinal fluid. Some people can't tolerate a spinal tap because of spinal deformities, or they've had lumbar spine surgery, or they're on anticoagulants, various reasons. But what we now have are blood tests, and these are available. I think when I showed you a similar slide 2 years ago, I said they're coming soon. Well, now we have them. And of all the various blood tests to diagnose Alzheimer's disease, a test called p-tau217 is the one that has high accuracy, 90% accuracy, which is the same accuracy as doing a spinal fluid examination or a PET amyloid scan. And so blood tests, of course, are the great equalizer. You can live in a rural area. You don't have to travel to some, fancy center where they'll do an LP or a PET scan. They're less expensive. They're more acceptable. Patients have blood draws all the time, and clinicians order blood tests all the time. So we really think this is a huge advance. And infusion centers, as I mentioned, here's just an example of an infusion center that opened in our building in February. Centrex is the one that runs this, Procuro, North York. And the fellow on your left was a study participant in the pivotal trial that led to the approval of lecanemab. And he absolutely, along with us, pioneered the drug and the trial and the benefits of the drug, and was thrilled to see the drug being launched in an infusion center. And something else coming that is so exciting, although I talk about Denanumab and Lecanumab being intravenous medications, so you need an infusion center, Lecanumab has a subcutaneous auto-injector formulation. And just earlier this month, the FDA approved the auto-injector for initiation of treatment, as well as previously for maintenance of treatment. So this means that patients don't have to go to infusion centers. People who are busy, they're working, they have poor venous access, fragile veins, they don't have to have IVs. They can give themselves the injection just the way people would inject with Ozempic or other drugs at home, or their family member can give them an injection. So it's a once-a-week auto-injector. It's being reviewed by Health Canada, and we hope that it won't be too long before it's approved for use. So lots of advances you can see. And what's next for Lecanumab and Denanumab? Well, very importantly, there are additional phase 3 studies going on even earlier, not the mild cognitive impairment or mild dementia stage, but what we call that preclinical stage, where people are still cognitively normal. And 2 very important studies are fully enrolled, and the results are highly anticipated. And the Lecanumab study is called the AHEAD study. It will read out in 2028. The Denanumab preclinical study is called Trailblazer ALZ 3, and the readout is expected next year, maybe the end of next year. If these trials are positive, this will be the catalyst for a huge change, because now we're talking prevention in cognitively normal people. And there may be such things as annual screening, population screening with a blood test like p-tau217 for those over age 55 to catch Alzheimer's disease early before people have to have symptoms and can go on a treatment to prevent them from developing symptoms. So I realize this is forward thinking, but let me tell you, the field's pretty excited and starting to prepare for this eventuality. So what other treatments might be coming? You've heard it's not all about amyloid, and there are tau treatments, there are treatments targeting inflammation, there are lifestyle modification treatments. Here's the drug development pipeline. It's crazy now in 2026, and this was just published earlier this month. When I showed you the drug development pipeline in 2024, it had 127 unique drugs under study at all phases of development. And you see the outer circle is phase 1, middle circle phase 2, and drugs that make it to phase 3 are those that we hope will cross the finish line. So 2024, we had 127. Now we have 158 unique drugs under development, tackling all different aspects of Alzheimer's disease, amyloid, tau, inflammation, growth factors, all kinds of, I won't go into all of the details, but even tackling ApoE4 to try and change it to act more like an ApoE2, really fantastic things. And about 3/4 of the drugs in this drug development pipeline are for slowing disease or arresting disease, whereas 27% are to improve symptomatic treatment. And so you need both. It's just like if you have, a headache and it's from a brain tumor, yes, a painkiller is a good idea. You don't need to have a headache, but that's not going to treat the underlying tumor. So you also need a disease modifying treatment. Absolutely same in Alzheimer's. We want to treat symptoms when they're there, but we want something that arrests or slows down the disease. And interestingly, there are 46 drugs, or 35% of the drug development pipeline, that consist of repurposed drugs. So taking drugs already approved for another indication, maybe another disease, maybe an anti-inflammatory disease, and trying it in Alzheimer's disease. So the advantages are that drug development program will be much quicker. We already have a lot known about the drug, safety information, etc. So a lot of variety here. And as I said, across the span, not just across phase 1, 2, and 3 do we have drugs under development, but across the entire spectrum of Alzheimer's disease, with prevention trials in the preclinical stage, many trials in the mild cognitive impairment and mild dementia stage. But we haven't forgotten about folks who have more severe disease, and there are also these symptomatic trials for them. So I will just in the next few minutes just highlight a few of the many programs that are very high interest that the field is particularly excited about. So I can't go through all 58 drugs, but just a few. So there is a next generation of anti-amyloid antibodies. So we've talked about Lecanumab, Denanumab. That's what we have right now. That's a huge advance over not having any disease-slowing antibodies. But there is a drug under development called trontinemab. Sorry, they all have funny names, trontinemab. And this uses a brain shuttle technology to get more drug into the brain, not just more drug, but more homogeneously distributed throughout the brain, and able to clear amyloid much more rapidly with almost no side effects. The main side effect we look out for is something called ARIA, amyloid-related imaging abnormality. And in short, that's swelling or little spots of bleeding that can happen with lecanemab or denanumab, mostly without symptoms, rarely severe, but it requires MRI monitoring, etc. With trontinemab, so far, we see almost no ARIA. So, you need a first in class, and you get better in class, then you get best in class. That's how drug development goes in any therapeutic area. And there are a lot of hopes about the trontinemab readout. So the study in early AD, that's the MCI and mild dementia study, or pair of studies, is fully enrolled. and we expect it to read out, but not for a couple of years. So anybody who's eligible for lecanemab or donanemab now doesn't want to wait for their disease to progress for a couple of years. But the study in preclinical Alzheimer's disease is about to start. And if any of you feel you are at risk for Alzheimer's, maybe by virtue of family history or ApoE4 carrier status, or just curious, get in touch with us, because this study is really going to be in high demand and fill up quickly. But it's such an important trial to see if prevention with trontinemab, a very safe drug, can be successful. Another set of approaches are genetic approaches. Rather than clearing amyloid or clearing tau that's already formed in the brain, what about shutting off production of those toxic proteins? And there are two drugs I'm mentioning here, again, funny names, mivelsiran, which achieves dramatic shutdown of amyloid production and without side effects related to shutting off amyloid. Its success is being seen in phase 1 and 2, and it will continue at some point going into phase 3. No timelines yet, but it's under study for Alzheimer's disease, but also something called cerebral amyloid angiopathy, for which there is no treatment right now, and for people with Down syndrome. And why Down syndrome? People with Down syndrome overproduce amyloid, and if we can help them shut off amyloid production, then they have a much better chance of not adding Alzheimer's disease to the challenges they already have with Down syndrome. Diranersen, and the bottom bullet, has just become the first drug to lower tau production and at the same time show clinical benefit. And this was presented just a week or two ago at the Alzheimer's International Conference in the UK, and it is moving into phase 3. So another opportunity coming your way, or to anybody interested that you know, to take the option of shutting down tau production very effectively in the hope of slowing disease, improving disease status. And finally, I'm so sorry for the name of this drug. Drugs don't get their easy to pronounce names until they are further along. So we're stuck with these complicated names. Valiltrimiprazate. Valiltrimiprazate. What is this? This is an oral drug now, not given by IV or intraspinal injection, a pill, which blocks the formation of the most toxic form of amyloid, which is not plaque, but the oligomers, the soluble large clumps. And there was recent success in phase 2 of valiltrimiprazate in those with mild cognitive impairment and 2 copies of ApoE4, and also in those who had a high burden of microbleeds. So people who would be excluded from lecanumab and denanumab, too many microbleeds on their MRI, or they have 2 copies of ApoE4, they now will have an excellent opportunity in a phase 3 study with valiltrimiprazate. So again, can't provide more information in a short talk like this, but exciting time. I think you're getting the message. There are lots of things that look very promising. So joining a trial is something that we love to shepherd people through if they're interested. We don't twist arms. This is an individual decision. But why would people join a trial? To pioneer with us, to access specialized diagnostic tests and treatments not otherwise available and without cost. So individuals do not pay for drugs or diagnostics or any tests when they're in a trial. That's all covered by a research grant. And they have access to the latest developments in treatment, sometimes several years before a drug actually comes to the market. So they've gained a lot of time in having the drug through a clinical trial. You have access to an expert team of specialists and close monitoring of one's condition, which is often a challenge to get outside of a clinical trial site in the real world, because specialists are busy, family doctors are busy. It's hard to get their attention. And the satisfaction of knowing one's doing everything for oneself, one's family, future generations, people we don't know. This is very rewarding. And so, you know, in summary, there's some key takeaways. Alzheimer's disease is a long and complex disease, but there are many opportunities to intervene now that we understand the biology much better and we have biomarkers. And if we diagnose and treat early, we get the best outcomes. So waiting until someone's more disabled is not the right approach. If you're concerned about someone or yourself, get it checked out. It's not all Alzheimer's disease, but it's hard to tell without going to an expert and getting the proper testing. And accurate diagnosis is possible not just with PET scans, spinal fluid, but now with a simple blood test. And that has really changed access and acceptability. There are 2 disease-slowing treatments approved in Canada, Lecanumab and Denanumab, and this marks a major advance, whereas previously we had only symptom treatments and we had nothing for mild cognitive impairment. Additional treatments, including those to prevent Alzheimer's, are under active study, and research absolutely provides the hope for the future. So don't doubt progress, help accelerate it. People who know this disease want to be involved, and you have many options. And I showed this last time, and many of you rose to the challenge. Have a baseline memory test to gauge against future change in memory. Join our prevention and treatment registries. You may be interested in a trial coming up or in the future. Undergo a cheek swab to check whether you have the ApoE4 allele and risk for Alzheimer's, and find out about clinical trials if you feel that you or someone you care about might benefit. And again, I think I showed this last time. I can never show this slide too many times. If we didn't have medical heroes, namely research participants, there would be no drugs in the pharmacy for diabetes, for COVID, for hypertension, nothing. So next time you go to the pharmacy, think about all the drugs that are on the shelf behind the pharmacist and all of the thousands and thousands of people who actually help develop those drugs by participating in clinical trials. It's really an interesting experience. And we all have a role to play in ending Alzheimer's. We do believe it's within reach to end this disease. And for sure, we don't want our children and grandchildren to have to deal with this. They'll have enough to deal with. The world is a little messy, but if we can get rid of Alzheimer's disease, that's one less thing for them to struggle with. So here's our lovely Justine, who's on the call with us today. If you have questions for her that I am not able to answer in our Q&A that's coming up right now, or if you want to get involved in whatever way you like, please note her direct line and email. So thank you so much for your attention. And Justine, maybe I'll stop sharing here so that I can see you as a group. And Justine, if you want to read out any questions that may arise or have arisen in the chat, that would be great.
Sure, absolutely. I'll put the email address and the phone number in the chat as well. One of the questions was answered a little bit later in your presentation, but another one that came up is, are there any ongoing research on targeted radioisotope treatment or targeted ultrasound wave therapy?
Yes, thank you for that question. There are, and it's mostly targeted ultrasound, but there are several lines of inquiry there, and we will have a study on focused ultrasound at Toronto Memory Program shortly, because we're very interested in the fact that for depression, certain networks are stimulated and you get a good response. And the idea is that if you can localize which brain networks deal with cognition and stimulate those brain cells, that you can get them to function better. So that is still a line of inquiry, but an active one. We don't have those therapies yet approved for the indication of Alzheimer's disease, but that may well come.
Thank you so much.
I think there was, oh, sorry, go ahead.
Oh, sure.
Sorry, Justine, you're on mute.
Oh, can you hear me now?
Yeah.
Yes, I can.
Oh, sorry. The next question is, are memory quizzes useful for diagnosis?
Yes, thank you to whoever raised that. So medications are important, but lifestyle interventions are very important. And one of the lifestyle strategies is to stay mentally active. So whether it's memory quizzes, Sudoku, travel, going to lectures, we all have different hobbies, music endeavors. any of those things are very helpful. And what you want to do is to give your brain some novelty and challenge. What you don't want to do is just kind of rote learning things or the couch potato kinds of watching a show things. You want something that's engaging and that stretches your abilities a little bit. So memory quizzes, sure, but if you hate those, do something you love and it will work even better. So we think this is important throughout the lifespan to build more brain networks and more brain cells. And yes, you can grow new brain cells as you get older. It's not all downhill, that you're born with a fixed number of brain cells. It's really never too late to engage in cognitive activities, and even better when you combine cognitive activities with some social activity.
Great, thank you. That's the last question in the chat, but I don't know if we want to open it up to unmuting and verbal questions.
Yes, please.
Sure.
Yeah, go ahead and unmute if you have questions, please.
Oh, we got one in the chat. Are there an adequate supply of the new drugs?
Yeah, what a great question. You know, drug supply is often an interesting topic, but the answer is yes. We have ample supply, and Canada was so late in gaining approval. You know, US FDA approved PMDA in Japan and South Korea and Europe and the UK. And so manufacturing really ramped up by the time we got approval in Canada. So yes, it's readily available now. There are no delays because of shortage of drug. The delays that happen are because people are not seeing their primary care practitioner soon enough or not getting referred soon enough.
I'm on blood thinners. Does that exclude me from the various drugs that, and why would that be? Is that because of side effects?
Yeah, thank you, Daryl. Yeah, thank you for sharing your information. It's very helpful. So Health Canada has said that people who are on blood thinners are at a higher risk of side effects of little spots of bleeding in the brain if they go on lecanemab or donanemab. Now, in the trials that led to the approval of these drugs, people were allowed to be on blood thinners and they actually did well. So Health Canada is one of these regulators that is very risk averse and they don't want to take any chances. And in doing so, they're actually denying people an opportunity for a treatment that might help them. So right now, if we're prescribing on label rather than off label prescribing, being on a blood thinner would mean no lecanemab or donanemab. What we have done sometimes is sent people to the US because there they don't have that same restriction. But of course, that involves the inconvenience of traveling back and forth for a treatment. But we are hoping to expand the indication, but also, very importantly, with the next group of drugs like trontinemab and other drugs coming, we don't expect to have those same exclusions. So yeah, it's tough. You don't want to leave anybody out, but right now, anticoagulants in Canada are exclusionary for lecanemab and donanemab. I should say that we were having lots of conversations, Daryl, with cardiologists saying, you know, here's the problem. Somebody's interested in lecanemab. They're on a blood thinner. Can they come off? Is there an alternative? Some people are going ahead and having a procedure called a Watchman procedure so they can come off their anticoagulant, or they go on dual antiplatelet meds. Of course, the heart's important, so we're not wanting to jeopardize cardiac health, but sometimes people don't actually need to continue on the anticoagulant regimen, so it's worth checking out.
Sharon, first off, thank you for an excellent presentation. I really enjoyed it. While we are on blood thinners, there's a lot of people on baby aspirin, people with heart problems. Has that been red flagged as a concern for these new era drugs?
Thank you. I'm really glad you asked that because when I say blood thinners, I'm referring to a very specific group like warfarin, rivaroxaban, baby aspirin, or even a full dose aspirin. That's not a problem. And being on clopidogrel or other drugs that work by targeting platelets, that's not a problem. You could be on even more than one aspirin plus another antiplatelet. So yeah, thank you for helping me clarify for everyone.
Thank you.
Pleasure.
I have a question. If you have Alzheimer's or dementia, but you also have fascia or vascular, are these drugs any good for that?
What a great question. It is common to have more than one pathology in the brain. And especially as we get older, we're likely to have some cerebrovascular disease, some hardening of the arteries, maybe even mini strokes, things like that. And if we confirm that Alzheimer's is present with a biomarker, so let's say somebody is PET amyloid positive or p-tau217 blood test positive, but they also have other things, maybe even, could be stroke, but it could be Parkinson's disease or something else. We would say, in most cases, we can treat the Alzheimer's component, and how much benefit you get is going to depend on how much the Alzheimer's disease is driving your symptoms versus the other conditions. So there's a bit of a question mark there, but we wouldn't automatically exclude people who had other conditions in addition to Alzheimer's. I hope that helps.
Yes, it does. Thank you very much.
You're so welcome. All of you are asking great questions. I appreciate it. You're making me better.
If I had the blood test done, say, over 6 years ago, and they found out that I have the genes for one of the parent, how often should I go and get myself blood tested again?
So if we're talking an ApoE or another genetic test, your genetics are for life, so you don't need to repeat it. But if you're talking about a biomarker like p-tau217, which tells us whether amyloid's accumulating, that would be the test that could be done. And if it's negative, you could repeat it in a year. Does that make sense?
Okay, yeah, makes sense. Thanks.
Okay. Good.
Can I ask a question? It's Bruno here.
Yeah,
Of
go
course.
ahead.
With regards to Parkinson,
Yes.
because we know 1/3 of the people with Parkinson end up with dementia/Alzheimer's. At what point should these people be tested, and or would it help them?
Yeah, it's such an important question, Bruno. Thank you. We know that with Alzheimer's disease, there is a very high rate of co-occurrence of a protein called alpha-synuclein, and that's the Parkinson's protein. So at least 30% of people with Alzheimer's disease, biomarker confirmed Alzheimer's disease, will also have alpha-synuclein. And vice versa, about 50% of people with Parkinson's disease will have amyloid brain changes. That's the Alzheimer's brain change. So in the pivotal phase 3 studies that led to approval of Lecanumab and Denanumab, we didn't include in those studies people who had overt Parkinson's disease because it would have been a challenge to sort out how much benefit and why. But now that we have the drugs approved, we are going on a case-by-case basis, trying to understand what our best assumptions are about how much the symptoms are from Alzheimer's, how much they're from Parkinson's. We don't yet have the prevention drugs approved for Alzheimer's. So if somebody had Parkinson's and no cognitive symptoms, we wouldn't be giving the Alzheimer's treatments now because they're to treat the cognitive symptoms of Alzheimer's. Does that make sense? But in the future, there'll be even more chewing on your exact question, who should we be screening for prevention?
I have another question for you.
Can I
Oh,
just
sorry. You want to go ahead?
a supplemental question?
Sure.
We know that people with Parkinson can develop Alzheimer's, and a third of them do.
Yes.
So should those people be involved as well in these drugs, not to cure Parkinson, but to prevent deterioration in terms of dementia or Alzheimer's?
Right. So as far as participating in a prevention research study, that will be challenging. We would need to find a protocol that allows people who have Parkinson's disease to participate in an Alzheimer's prevention study. However, in terms of outside of clinical trials, if one has concern about cognitive symptoms, then one could have biomarker testing, let's say p-tau217, to see if they already have Alzheimer's brain changes. And then that would sort of open up treatment opportunities. So I'm not trying to hedge here. It's a bit complicated, and I'm happy to if this is of further relevance to you, we can talk about it offline or contact Justine and see how we can be helpful.
Thank you.
You're very welcome.
Right,
I
Karen.
I have a
quick-
question.
Hold on. Let Karen go first. Go ahead, Karen. Sorry. Go ahead, Karen.
I've had a friend who's been trying to get into a memory clinic. In some places, they're like number 1,000 on the list. How do you get into these places if you can't get in for treatments?
Yeah, that breaks my heart that people are doing the right thing. They're saying, hey, I want to be seen, and then they sit and wait. So we have tried very hard at Toronto Memory Program to be as nimble as possible. We triage every referral so that people don't wait and that they're matched with the right practitioner. You know, if they're interested in prevention, they're interested in clinical trials, they're symptomatic, they need linkage to services, whatever it is, we try to fast track into the right stream. So I'm not sure what geography, like we don't have a catchment area.
Well, this was in the Brampton area.
Oh,
and,
Brampton. Okay, so not
and the Brampton Hospital is over 1,000 ahead.
Yeah, no, we can do better. So
Okay,
if we
I'll
can be
pass that
helpful to
on.
you, I'm not trying to steal people from
It's
Brampton.
just it's shocking, you know, you're hearing get treatment quick, but then you can't get in.
Yeah, you know, you're right. You're absolutely right. Something has to change. And we're probably all listening to the news this morning about physician burnout and
Yes,
leaving, and it's like, oh my goodness, okay, well, we need to have our healthcare manpower here. So right now we probably are the quickest place to get in, and you know, especially if somebody is early in their symptoms and is interested in the possibility of one of these disease slowing treatments, we go pretty fast and get them in very quickly. So yeah, so please again reach out to Justine if we can facilitate a referral or help in whatever way.
Yeah, great, thank you.
You're very welcome.
Go ahead. Who was next asking a question?
Yeah, so you guys had or you mentioned I think earlier a baseline memory test.
Yes.
Are those available? Are they free? Are they like where can you online?
We prefer to do them in person, but we can do them online. Again, Justine will be the person to liaise with. We offer these free because we realize how hard it is for people to get a baseline memory test, and it's important. The first time I see someone and do their cognitive testing, I don't have anything to compare it with. So we think even if you're healthy, you know, not worried about symptoms, it's good to have a baseline test because people don't need to score 30 out of 30 or 100 out of 100 to be normal. They need to be there, you know, consistent with themselves. And clearly, if there are symptoms, having a test sooner rather than later is also a good idea. So yeah, long story short, we offer these for free. We can do them online. We can do them in person, whatever is the most convenient.
Any more questions? All right. So this presentation will be sent to us by Dr. Sharon and Justine. So you guys will have a copy of it. This is taped. So once it's fine-tuned, we will put it online for you guys to watch it again and again. And if you have any other questions, please go ahead. Ask Justine or Sharon. Does
or
anybody have
questions
questions?
after the fact, please don't hesitate to reach out. Really a pleasure speaking with all of you and getting to see some of you. And thanks for spending the time together. It's an important
Thank you so
topic.
much.
Thank you so
We need
much
to hope
for all your help.
Nazma, just a quick suggestion. When you forward the slides of this presentation, can you also attach the one of the previous one, which talked about the memory test and the other stuff? So it will be really useful if you can.
Yeah,
Thank you.
sure, no problem. Now, when you exit, there's a survey. If you can make sure you fill out a 5-question survey to see how if we can do anything better, anything else you want the topics to be brought up on Zoom. So let us know, please.
Thank you very much for everything you're doing, guys. This is wonderful.
Thank you.
Thank you.
Thank you.
Thank
Really
you so
appreciate your
much.
encouraging
Thank
words.
you. Thank you,
All the
Justin.
best.
Thank you,
Bye
Sharon.
now. You're
Bye.
so welcome.
Bye.
Bye,
Thank
everyone.
Thank you. Bye-bye.
Bye.
Thank you.
You're welcome, Audrey.